And Christopher Bailey is Senior Vice President at the Virginia Hospital Healthcare Association.
Thank you, Eileen. Can you all hear me all right? I tend to walk around a little bit rather than standing still. Well, good afternoon. Oh, come on, you can do better than that. Good afternoon.
Good afternoon.
It's a beautiful day outside, so thanks for coming in and spending a couple of minutes talking about a fairly arcane health policy topic. What I'm going to try to do is zero in on some use cases that the all-payer claims database can provide for a variety of stakeholders. Obviously, I work for the hospitals and health systems in the state, so I'm most familiar with the uses that we saw, the value we saw in the APCD. But I'm going to draw from experience in Wisconsin, where they've had a similar model in place for a couple of years now. These are real-world, actual use cases underway in another state. But what motivated us to seek the establishment of an all-payer claims database? Well, there were really these observations, that first, the healthcare costs are on an unsustainable trajectory, especially when it comes to public healthcare spending, that most healthcare costs relate to patients with one or more chronic diseases. Michael's slide earlier highlighted that for you. This is healthcare's 80-20 rule, 20% of the patients representing 80% of the costs. The American healthcare system does a lot of things extraordinarily well. We've got more technology. We are the world's R&D shop when it comes to healthcare. So we have the latest and the greatest. But one thing we do not do well, and comprehensive data like APCDs tend to help with this, but one thing we don't do all that well is managing complex chronic conditions over time for patients. We have lots of silos in healthcare delivery. We have lots of silos of healthcare data. One real value of the APCD, it gives us a comprehensive view of patient experiences for all services delivered in all settings over time. So a tool that's especially helpful for tackling that second bullet, where 20% of the patients that require and consume 80% of the resources. Even though we spend a lot on healthcare, there's waste both in terms of overutilization of some services relative to evidence-based practices and underutilization of high-value services, especially around prevention. And wide variation exists in adherence to best practices. It turns out that healthcare is not exempt from the basic rules of Deming and Drucker, that variation is the opposite of efficiency. If you lower unwarranted variation, you will improve both quality of the production system and cost simultaneously. To drive that sort of value improvement, though, you need comprehensive information. And the APCD is a big piece of that. Not in and of itself the full answer, but is a key piece of it. So these are the key, from our point of view, the key components of healthcare transformation that'll drive better results for everyone, patients. You know, I use that phrase, skin in the game, all the time, too, that Laura Lee mentioned, about to refer to financial skin in the game. But when it comes to healthcare, whether you're paying $1 out of pocket or not, we've all got skin in this game, don't we? It's our skin, it's our body that can be affected by healthcare delivery. So it's improving the full process for the patient's point of view that we can redesign the delivery system, redesign payment models, because we get exactly the results you should expect when you pay for volume, which is the historic pay for each unit of service. It rewards volume improvement. Volume increases, and transparency is the way to support both care delivery redesign and payment reform. People who work on improving health care, including me, tend to fall down into 3 or 4 tribes when it comes to what the answer is. Everybody seems to agree with that first slide on what the ills of the system, but people drive into or separate into 4 tribes when it comes to the prescription. What's going to solve healthcare's cost and quality and practice variation issues? Tribe number 1, health IT. If we get a comprehensive electronic medical record and data can follow the patient from place to place, everything will get better. Tribe number 2, prevention and patient engagement. If we get people to focus on doing the right things, eating the right things, exercise when they should, enjoying a little less red wine at night, some's good for you, I want to hasten to add. That's going to be this solve all ills. Other people argue we fix coverage, we get everybody health care coverage and give them access to care. That'll solve the quality and cost ills. And the fourth tribe is payment. If we figure out how to pay for the right results, that'll drive improvement. My own view is, I'm a big believer in payment reform. I think we've got to do a lot of that. We've got to do it quickly. But I think the answer is you've got to do all four of those. We've got to fix coverage. We've got to do a better job on prevention and patient engagement on prevention. We have to fix IT so we have real clinical data at the point of care. And we need to do payment reform. Transparency is a key supporter of performance improvement and payment reform. And this is the area, the sort of transparency level we're focusing on with the APCD is this third level healthcare transparency. Share meaningful organizational performance, quality, and costs with across all stakeholders on equal terms. That'll support and provide pointers to the sort of delivery system changes and payment reform priorities that deeper dives will need to accomplish. So these are, we would agree with most of those initial opening thoughts about what the ills of the system are. Improving quality, reducing risk, and eliminating waste are the key to value. We should all be working together to get to that outcome. And I've talked about the obstacles. So these are the questions or the problems APCDs can help solve. Drawing from the Wisconsin experience, Julie Bartles, Lordy mentioned, was a key advisor to us in developing and supporting the legislation, and we were very thankful and very helpful that she was willing to come down and help us as we got down to the nitty-gritty in designing the contracts this summer. But many of us on this stage lost a good part of our summer to negotiating the terms around APCDs, but it is time well spent. And if you step back for a minute, if we'd had a mandatory model, it would have taken at least this long, probably twice as long, to come up with standard data submission terms and standard data use terms. It would have taken the public regulatory process, which takes at least 18 months. And in 9 months, we've been able to accomplish about the same level of specificity and standardization under the private voluntary model. So let's take an employer case. What would an employer get from an APCD? If the goal is to keep the employees healthy and productive, APCD can be useful to benchmark utilization by employees to identify opportunities. Are they taking full advantage of their care access opportunities to get the services they need to manage their conditions? What providers are doing the best job at managing diabetics, if that's a high volume condition for your employees? What groups of physicians tend to have higher compliance rates for their patients for diabetes management? And you can track the impact of changes in plan design on total cost for care, total utilization for care over time, and you can compare your employees' experience against the experience of other employers in other parts of the state. From the provider point of view, you get to benchmark utilization of patients to identify opportunities as well as best practices. You can get us, we have a good insight today into care provided in the hospital, a bit of insight into care, the consequences of care 30 days post-discharge. But after that, things are fairly opaque. And if we want to be able to manage care over time for an episode of care, having this sort of comprehensive information the APCD that can provide is going to be tremendously helpful. This is a real life example from Wisconsin showing physician groups, sample family practice groups, their relative performance on both a quality index for managing a particular set of patients and a standardized cost index. So managing a similar set of patients, the place you want to be, obviously, if you look at a slide like this, is somewhere in the upper left part of the quadrant, where you are both high on quality and low on costs, and you can see the level of variation. You provide meaningful, that is comprehensive, detailed, high-power data to physician groups like this, and I guarantee you, physician groups like us are competitive people. Nobody likes to be in location 3 there to the right. It will drive people to try to move to performance levels in the upper left. Even without payment reform, meaningful, comprehensive data like this, which you cannot get unless you combine data across payers and have a comprehensive view of patient experiences, will be significantly motivating to better value. You pair this sort of data with some significant payment reforms and bundle payments around episodes of care, and that will further accelerate performance improvement. So APCD is a pointer and is a supporter of the sort of other changes that can drive significant improvement. And Laura Lee's spoken to the payer uses already, so I won't belabor that. So what are they doing in Wisconsin beyond producing these very powerful provider performance comparisons? They're doing a couple of significant payment reform initiatives, and so they're designing different ways to pay for services in a similar fashion across payers. Each payer can decide how much they're going to spend for that given condition, but they're going to define the bundle the same way. Again, a fairly powerful way to accelerate performance improvement. And they're doing it in two areas. They're doing it for both total knees and for diabetes. So not just chronic conditions. This is a total knee replacement, thankfully not a chronic condition. But they did notice when they looked at the data, very significant variation in utilization patterns and aggregate costs across settings for treatment of total knees, like a 10-fold difference in the per person cost for a total knee with patients with similar conditions. And so they're working both with the local medical society as well as with payers to narrow that variation and pay for a bundle of services around those total knees. Very, very powerful signal to the environment, the market there, and they're doing something very similar with diabetes. Again, several payers at the table, all providers at the table, designing the bundle the same way and figuring out how to pay differently to reward better outcomes, better quality, better costs. And close with a couple of quotes, because from our point of view, the main stakeholder that we're trying to support with providing this information are major purchasers. And Sarah Wilson, who's going to follow me here, represented the employers most consistently through the process. And there's a quote here from her about wanting to have access to as detailed data as possible. And this was a key accomplishment in these stakeholder negotiations, to have available to all stakeholders on equal terms a detailed database that allows them to use that data to spur innovation and to do their own value improvement projects. But once we've protected patient confidentiality, which Michael has experience with and will do in this case, once we've done, and this is particularly important for my constituency, once we've assured an accurate attribution of patients to a provider or a group of providers, once we've protected against the release of proprietary information about differential pricing for individual units of services for providers and plans, and that's required in the statute. So once we've done those three things, most everything else in the database will be made available in a manipulable form to all stakeholders for their use to drive innovation and value improvement. And that's a significant accomplishment. You don't see that in all APCDs. Some APCDs only have available written reports that various experts have done. This is going to provide, and the Virginia model is going to provide a useful database for all stakeholders to use on equal terms. And it took us a while to get there, but we're very thankful that we did. And that's it, and I'll turn it over to Sarah. Thank you.
Thanks, Chris.